Good evening, everybody. Welcome to this evening episode of Pursue. This is Pursue 4B, and this is Adv Path, and we are streaming live from Kolkata. And today we have with us Colonel Tanushri Mukherjee. She's an MBBS MD from she's an MD from Armed Force Medical College, Pune, and she's also done a DNB, MNAMS. She's a professor in the Department of Pathology, Command Hospital, Kolkata. She's trained in Oncopathology and she's an affiliate member of the Royal College of Pathologists. Today she'll be talking about the neoplastic and non-neoplastic lesions of cervix. But before we start, please let me request you to keep your mic muted, your camera off, and please don't share your screen. And when you join, please press join now and don't press present. With this, let me request Colonel Mukherjee to start her lecture. Ma'am, please share your screen and start your lecture. Thank you so much. Yeah, we can see your screen. Just make it full screen, please.
Yes. Good evening. So today's lecture will be on cervix, the non-neoplastic and the neoplastic lesions with specimen handling, grossing, IHC and the updates. So the topic will be covered with keeping in view to write a full answer of the cervix theory paper, like the anatomy and development, HPV virus, because it has got very important implications, the benign lesions, the cervical squamous intraepithelial lesions, squamous cell carcinoma, the endocervical adenocarcinoma in situ, cervical glandular intraepithelial neoplasia, and adenocarcinoma of the usual type, and the non-HPV related, and the mesenchymal and mixed epithelial mesenchymal neoplasms and other cervical neoplasms. So benign lesions, they are important. Why? Because you have to differentiate it from the neoplastic. Because as you will see further, there are so many entities and there is so much overlap. So you have to be very, very careful. So these are all the entities which are covered under the benign lesion. Cervix. Cervix term is taken from Latin meaning neck. Is the most inferior portion of the uterus protruding into the upper vagina. Cervix measures 2.5 to 3 cm in length in the adult nulli gravida. The external arc is circular in the nulli gravida and slit-like in the parus. The blood supply of the cervix is provided by the descending branches of the uterine artery. Development. The majority of the mammalian female reproductive tract develop from the Mullerian duct, which form as invaginations of coelomic epithelium into the urogenital mesenchyme, through which they grow chordate. Histology. The cytology I will be taking later when I take the Bethesda classification. Here I will just mention the cell type. The mature non-keratinized squamous epithelium of the exocervix is similar to the vaginal epithelium. It is divided into 3 zones. The basal, parabasal or the germinal cell layer, which is responsible for continuous epithelial renewal. The stratum spinosum, the dominant portion of the epithelium, and the superficial zone containing the most mature cell population. So there are the basal cells, which acts as the reserve cells, and the parabasal cells. Here you can see the cytology as first the superficial cells, then the intermediate cells, and there are the parabasal cells, and there are the endocervical cells. The parabasal cells typically form a layer that is 1 to 2 cells thick over the basal layer. Under normal conditions, the basal layer acts as reserve cell layers and mitosis are only identified in parabasal cells. In the lowest photomicrograph, you can see the atrophic squamous epithelium which is devoid of glycogen-rich vacuolated cells. This is just a comparison between the normal squamous epithelium and the atrophic squamous epithelium. Then the endocervical mucosa, as you can see, and sometimes you can see lymphoid follicles, as you see in the fourth photograph in the cervical stroma. Then the transformation zone, which is very important. It is histologically characterized with the presence of metaplastic epithelium. It is the region between the original squamocolumnar junction and the post-pubertal functional squamocolumnar junction. The concept is extremely important because the pathogenesis of squamous cell carcinomas of cervix and its precursors, it all starts here. In older and post-menopausal women, the functional squamocolumnar junction is nearly always located within the external os. Then there is effects of estrogen and progesterone, which is cyclic, and the secretions, they change with the cycles, and then there can be Langerhans cells and lymphoid-derived cells because the immunity, the mucosal immunity is an important component of the host defense mechanism against viral and bacterial pathogens. The IHC of the normal cervical tissues. Here I will stress on the importance of P16, which shows block positivity in cases of squamous intraepithelial lesions. So, the tumors of the uterine cervix, it mentions all the benign as well as the malignant lesions. So, the numbers are many, but I will try to touch upon most of them. Then there is a pre-decidual reaction and the area stellar reaction. Pre-decidual pseudodecidual reaction of the stroma, either patchy or diffuse, as shown in the upper photomicrograph, it disappears by 2 months postpartum. The lower photomicrograph shows the area stellar reaction of the endocervix. During pregnancy, the gestational area stellar reaction can develop in both endocervical gland and ectopic endometrial glands within the cervix. And it can look very much aggressive, and you can confuse it with adenocarcinoma in C. Then squamous metaplasia is replacement of the mucin-producing columnar epithelium by stratified squamous epithelium. It can be mature, immature, or atypical, and there are two mechanisms by which there is squamous metaplasia. One mechanism, there is direct ingrowth from the native portioepithelium bordering the columnar epithelium, which is known as squamous epithelialization. And second mechanism involves the proliferation of undifferentiated subcolumnar dissolved cells of the endocervical epithelium, which differentiate into squamous epithelium. Then there can be tubal metaplasias and tubo-endometrioid metaplasias of the cervix. Tubal metaplasia can be quite extensive and can occasionally be mistaken for endocervical glandular neoplasia. But the cytological features are bland, there is lack of mitosis, and prominent cilia is seen at the apical surface of tubal metaplasia. Then there can be reactive atypias like squamous reparative atypia in the first photograph. Then there is reparative changes developing in immature metaplastic squamous epithelium. The third micro photograph shows endocervical reparative atypia, and fourth is the papillary endocervical reparative change, which is sometimes called as the papillary endocervicitis, but here I mentioned it that it is called as papillary endocervical degenerative change, and there is marked inflammation of the stroma. Then there can be hyperkeratosis of the cervix and parakeratosis as seen in the lower photograph. The pycnotic nuclei are retained in the superficial cell there, and both can be accompanied also. Then infectious cervicitis, the causes are many. It could be chlamydia, Neisseria, mycoplasma, viruses, HPV, fungi, candidas, aspergillus, and protozoa. Condyloma acuminata I mentioned here because of the infection, but later on I will cover it with the low-grade squamous intraepithelial lesion. It is L-cell CIN1 condylomatous variant. It looks like a genital wart on the mucosal surface. Then the pseudo-neoplastic glandular conditions, hyperplasias and endometriosis. Here we have to differentiate it. There can be microglandular endocervical hyperplasia. It is a benign proliferation of endocervical glands. Incidental finding on a cervical biopsy, cone biopsy, or a hysterectomy specimen. It may resemble a cervical polyp. Patients may complain of postpartum bleeding. It may present in a single focus or in multiple foci. There is an adenomatous pattern here with cuboidal lining cells and focal squamous metaplasia. Then there may be lobular endocervical glandular hyperplasia. It is a rare form and it can be sometimes found only with a distinctive gastric phenotype. It is pyloric gland metaplasia, and a special IHC is there, that is HIK1083, which is specific for gastric pyloric nuisance. Then there is lobular endocervical glandular hyperplasia, which is confined to the inner one half of the cervical wall, and the gland lining cells are devoid of malignant atypia, and mitosis do not exceed 2/10 high power speed. And here you have to differentiate this from the gastric type of adenocarcinoma like Adenoma Malignant, minimal deviation adenocarcinoma. So this is the diffuse laminar endocervical glandular hyperplasia, endocervical glandular hyperplasia, then some mesonephric remnants and florid mesonephric hyperplasia. These are all the benign lesions, but it has to be carefully seen and differentiated from the neoplastic lesion. Then tunnel cluster, which can be found incidentally in cone biopsy, from hysterectomy. It could be type A or type B. These are lobular aggregates of benign endocervical glands in the cervical wall. Type A are composed of small non-cystic glands, and type B are composed of cystically dilated glands. This is having excellent prognosis and no risk of recurrence of malignant transformation, and totally asymptomatic. So microscopically, as I said, it could be type A and type B, or sometimes it can be of mixed pattern. They have got no clinical relevance and do not need to be mentioned in the pathology report. The differential diagnosis, but they are minimal deviation adenocarcinoma, visual type endocervical adenocarcinoma, adenocarcinoma in situ, nephrotial cyst, or mesonephric nephron or hyperplasia. Then endocervicosis of the cervix and endometriosis of the cervix. These are all conditions which can be encountered. Then the polypoid lesions of the cervix, either they could be polyp or a microglandular endocervical hyperplasia, decidua, granulation tissue, a leiomyoma, a fibroadenoma, squamous papilloma, condyloma acuminatum, papillary adenofibroma, squamous cell carcinoma, adenocarcinoma, or a sarcoma. Mesodermal stromal polyp or a placental site trophoblastic nodule can also encounter. Then papillary adenofibroma of the endocervix and Mullerian papillomas, which show papillary projection. Now I come to the precursors of the squamous cell carcinoma with a little bit about the human papillomaviruses. The cervical cytology and all I will not cover in this lecture. That will be in the subsequent lecture, the Bethesda system. The squamous cell precursors, it has been agreed upon that it should be classified as a two-tiered classification, low and high-grade intraepithelial lesions, because it is more biologically relevant and histologically more reproducible than the three tiers CIN1, CIN2 and CIN3 terminology. Approximately 1/3 of low-grade squamous intraepithelial lesions show diffuse so-called block-positive P16 immunostaining involving the basal and parabasal cell layers. So, this low grade corresponds to CIN1 and the high grade corresponds to CIN2 and CIN3. About HPV and their mechanism of action, they are the epitheliotropic viruses with double-stranded DNA genomes, 8 coding genes defined as early or late, depending on when they are expressed. 200 HPVs have been identified. The main mechanism of action is reduction of intracellular availability of the host cell cycle inhibitor oncosuppressor proteins P53 and retinoblastoma. E7 proteins bind and inactivate the retinoblastoma protein. E6 proteins bind P53 and directs its rapid degradation. Mutation of P53 is a rare phenomenon seen in high-grade cells and in HPV-positive invasive cervical carcinoma. It's better we say high-grade cells, SIL, squamous intraepithelial lesions. Then how do you define chronocytosis? Very important thing, very basic, but everybody should know that the marked variation in the nucleosides at least 3 times, dark chromatin, irregular resinoid nuclear membrane. For the low-grade squamous intraepithelial lesion, it could present as the exophytic condyloma in a verruciform growth pattern. These are caused by HPV type 6 and 11. And these are rare conditions. Immature condyloma and flat condyloma. HPV 16 and HPV 18 produce more rapidly growing and larger lesions. Polypocytosis is usually most prominent in the upper third of the epithelium. The surface cells may exhibit parakeratosis or hyperkeratosis with bi or multinucleation. L cells must be distinguished from mimics of L cell due to a variety of infectious or inflammatory processes that are unrelated to HPV infection. This I have shown earlier, the condylomatous variant of low-grade squamous epithelial lesions. Then high-grade squamous intraepithelial lesions, which corresponds to CIN2 and CIN3, nuclear atypia in all levels of the epithelium with variable degree of surface maturation. P16 being strongly expressed. In aceto-white colposcopic appearance, you see a aceto-white well-circumscribed lesion on the external os, and the lower photomicrograph shows H cell with metaplastic features with P16 staining, strong diffuse positivity, and the other end photograph, the HE and the IHC shows stratified mucin-producing intraepithelial lesions, SMILE. This H cell shows both mucinous and squamous differentiation with high Ki67 labeling index and stains positively for P16. And the therapy is conservative, just cryosurgery, laser ablation, or a loop electrosurgical excision procedure. The variants of H cell, it could be keratinizing H cell or a papillary squamous carcinoma in situ, or a non-invasive papillary squamotransitional carcinoma. High-risk HPVs are found in over 90% of cervical high-grade squamous intraepithelial lesions. Biologically, HPV can be thought of a clonal expansion of cells that derives to proliferate by the abnormal expression of HPV E6 and HPV E7 in cells still capable of cell division. This is a table which shows the distinguishing features of low-grade and high-grade squamous intraepithelial lesions. HPV type 16 and 18, high-risk type with HCL. Chronocytosis present in low-grade squamous epithelial lesions. Ploidy mostly diploid or polyploid in low-grade squamous intraepithelial lesions. Abnormal mitotic figures are frequent in HCL. Location of unsatiated cells and mitotic figures seen in lower third in low-grade squamous intraepithelial lesions and in upper two-thirds in HCL. So what you see here, in HCL there is presence of nuclear atypia with increased mitotic index with mitosis in the upper half of the epithelium, loss of cell polarity, abnormal mitotic figures, and markedly atypical and bizarre cells. These are the photomicrographs showing HCL with how to differentiate from the immature squamous metaplasia with abnormal parakeratosis. Another entity is superficially invasive squamous cell carcinoma or the early stage invasive squamous cell carcinoma. Is defined by less than or equal to 3 millimeters invasion in depth by 7 millimeter in length without capillary lymphatic space invasion, and patients are amenable to conservative excision, so this is very important, and margins are of vital importance. As per the figure, we have seen here the staging here, T1A, this is stromal invasion 3 millimeter or less in depth and 7 millimeter or less in horizontal spread. So the measure, the surgical margins is important because therapy is more conservative than that for stage 1A2, and treatment is often individualized based on the definition of the lesion, the lateral extent, and the factors. Now, squamous cell carcinoma and variant. It's an invasive epithelial tumor composed of neoplastic cells with varying degrees of squamous differentiation. It's the most common type of cervical carcinoma. Nearly all cases are associated with high-risk HPV, predominantly with more HPV 16, more common in low-resource countries. Fourth most common type of cancer and cause of cancer mortality. Most patients are 40 to 54 years old. Sites arise at the squamo-columnar junction of the cervix. Most infections with HPV spontaneously regress, but it progresses. As I told earlier, the mechanism of high HPV-induced carcinogenesis takes place. Retinoblastoma inactivation leads to overexpression of P16, a tumor suppressor gene involved in cell cycle regulation by inhibiting cyclin-dependent kinases. So we are by IHC using P16 as a surrogate marker for high-risk HPV. And then there are vaccines for this, which is recommended is 3 doses for adolescents and adults of any gender aged 15 to 26 years. Etiology, younger age, immunodeficiency, smoking, multiparity, early age at first birth, chronic inflammation, positive family history. This can all be the causes. Clinical features, cervical mass, general bleeding, pain, post-coital bleeding. Prognostic factors are tumor stage, patient age, depth of invasion, disease volume, lymphovascular invasion. Better prognosis for lymphoepithelial and varicose variants. Worse prognosis with lower CD4 counts in HIV seropositive patients. This is the figure staging of the cervix uteri, and this is the growth which we see stage 1 confined to the cervix, stage 3 which involves the lower third of the vagina or extends the pelvic wall, and stage 4 the carcinoma has extended beyond the true pelvis. So this is stage 1, this is the stage 2, this is stage 3, and this is stage 4. Microscopically, tumor cells infiltrate as irregular anastomosing nests of single cells. Lymphovascular invasion may be present. There is mutations in PI, K3, CA most frequently, low frequency of KRAS mutations, TP53 mutations in 15% of cases with loss of heterozygosity in multiple loci. Then histologically typed as invasive carcinoma into keratinizing and non-keratinizing. WHO has now kept small cell undifferentiated carcinoma with neuroendocrine features as a separate category. So for the keratinizing carcinoma, you have to have keratin pulse which are composed of clusters of squamous cells that have undergone keratinization and arranged in a concentric nest. The variants could be this: keratinizing, non-keratinizing, warty, chemotransitional, lymphoepithelial-like spindles. Gradings, it could be well differentiated, grade 1, moderately differentiated, and poorly differentiated when you can't recognize keratinization and will have to respond to IFC. Clear-cut squamous differentiation manifested by keratinization may be difficult to find in poorly differentiated squamous cell carcinoma. Prognostic features: stage is the most important prognostic factor. Histologic typing and grading have little direct influence. Tumor size, depth of invasion, parametrial involvement, and nodal status are important. Three basic modalities for squamous cell carcinoma: surgery, radiation, and combination of radiation and surgery. And I will subsequently tell about the specimens what we receive. Then the basaloid squamous cell carcinoma, a radical variant which is very rare, dual endoscopic form of squamous cell carcinoma, and a papillary variant with thin or broad papillae with fibrovascular pores lined by multilayered epithelium with squamous differentiation resembling high-grade squamous intraepithelial lesions. IHC, you can see pancytokeratin, CK56, EMA, P63, P40, P16 diffuse block-like staining, PDL1 positive in 1% of cases, and CK7, taxate, GATA3 can come positive. Differential diagnosis could be clear cell carcinoma, depending upon the type. It could be adenoid basal, adenoid cystic, small cell neuroendocrine. So differential diagnosis are too many. So how do I section the tumor? Fission of the transformation zone or leaf procedure. You have to do a serial slicing from one edge to the other in a sagittal and parasagittal plane perpendicular to the transverse axis, or in a full cone excision biopsies, serial wedge-shaped slices according to the hours on a clock face, and it should be submitted in entirety. Tumor involvement of the parametrial and paracervical tissue should be noted, and it may determine the method of dissection and block taking. The paracervical tissue may need to be inked. It can be examined microscopically along with the main tumor section. And maximum tumor thickness invasion into the cervical stroma is also very important. Parametrial involvement is a poor prognostic indicator for early stage cervical carcinoma regardless of lymph node status, and is an adverse prognostic indicator for advanced stage cervical carcinoma. Specimens could be simple hysterectomy or trachelectomy, then radical trachelectomy, or a radical hysterectomy. Today now it is not the standard treatment, especially in resourceful countries. In developing countries still we receive a VADA and hysterectomy, but in developed nation with a proper screening program, this is not too much frequent, where the every parametria, vaginal cuff, pelvic, para-aortic lymph node dissection with the uterus, cervix, everything is excised. So when we receive over the end, you have to report like this, in which you mention the cervical adventitial margin, the various granule cut margins, then ovary, parametrium, and the histological report also mentions all the. So, some questions combine which of the following statements is true regarding squamous cell carcinoma of the cervix. Most are associated with high risk HPV and arise from a precursor lesion HSIL. And more significant risk factors include persistent high risk HPV infection, HPV 16, history of HSIL, multiple sexual partners, multiparity, smoking, and immunodeficiency. Then the glandular tumors and precursors, which includes adenocarcinoma in situ, the intraepithelial lesion containing malignant appearing glandular epithelium that carries a significant risk of invasive adenocarcinoma if not treated. Typically occurs in young women in their reproductive years with an average age at presentation of 38 years. Past examination has low incomplete sampling of the endocervic, as well as inherent difficulty in distinguishing benign from neoplastic glandular epithelium in cytologic separation. Adenocarcinoma in situ almost always arises at the squamocolumnar junction transformation zone, and in 30 to 50% of cases, adenocarcinoma in situ is associated with a squamous intraepithelial lesion, which can be low or high grade. Then, histologically, what we see here, normal cervical glandular architecture is preserved with glands being lined by crowded cells, enlarged, hyperchromatic, stratified or pseudostratified nuclei, abrupt transition from normal to neoplastic epithelium. Then there is an early form of conventional adenocarcinoma in situ is recognized. It is an early form of disease because it occurs in a younger age group. It involves the superficial aspects of the cervical mucosa and it has less pronounced atypium. Similar to conventional adenocarcinoma in situ, this variant is associated with high risk HPV and thus is also strongly positive for the biomarker P16 as shown in this photomicrograph. Initial diagnosis of adenocarcinoma in situ could be due to a tubal or tubular endometrioid metaplasia, endometriosis, ariostolar reaction, radiation effect, or cervicitis. What we see here is the nuclear stratification, hyperchromasia, nuclear enlargement, which is present, mitosis is present, apoptosis is present. It may have a complex architecture, and the mid-1 or the Ki67 labeling is high. Then adenocarcinoma, not otherwise specified, 10 to 25% of all cervical carcinomas. This increase has resulted from decline in squamous carcinoma secondary to screening programs and better identification of glandular lesions in cervical cytology samples. These are also associated with high risk HPV, most commonly types 18, 16, and 45. Clinical features are abnormal uterine bleeding and a mass lesion, and what we see here in histopathology, common glands with heteroarchitectural atypia that infiltrate the cervical stroma. A surface component with papillary architecture may also be prominent. Then there is endocervical adenocarcinoma of usual type, most common form of endocervical adenocarcinoma with relative mucin depletion. The usual type of endocervical adenocarcinoma constitutes about 90% of adenocarcinoma of the surface. Large pools of mucin may occasionally be present in the stroma. Then the mucinous carcinoma not otherwise specified, which is shown in the upper microphotograph, and the lower microphotograph shows the mucinous carcinoma signet ring cell type, a rare adenocarcinoma that shows focal or diffuse signet ring cell differentiation. Then here we are seeing the minimal deviation adenoma malignum. Now what I see here in the WHO is the new category of endocervical adenocarcinomas, gastric subtype. Extremely well differentiated are called as adenoma malignum, which is rare 1 to 2%, not associated with HPV, occurs in the reproductive age group, associated with Peutz-Jeghers syndrome, and the STK11 gene is involved. Deeply infiltrative, irregular glands with bulbous protrusion. IC positive 7, PAC3, CDX2, HIK1083, MUC6, TEA, CK20 and neuroendocrine markers may be positive and is loss of PAC2. Then below glandular carcinoma, this is a variant of endocervical adenocarcinoma with distinct exophytic villous papillary growth. Typically occurs in the younger age population. It presents as an exophytic mass. Mitotic figures and pseudo-fetification are present. And the villous fronds are characteristic. These tumors have distinctive cellular fibrous stroma with prominent spindle component. HPV type 16, 18 or 45 are the main causative genotypes identified. When superficially invasive, this variant is only rarely experienced for metastasis and has an excellent prognosis. Conservative management has been suggested as appropriate only in superficial lesions of pure villo-glandular morphology without high-grade atypics and with no lymphovascular invasion. Then there is the endometrioid carcinoma, an adenocarcinoma arising in the cervix that has endometrioid morphological features. They are similar to usual type endocervical adenocarcinomas. They are morphologically similar to the endometrioid adenocarcinomas arising in the uterine corpus, and for differential diagnosis is with endometrial adenocarcinomas of endometrioid type extending from the uterine corpus. They are typically diffusely and strongly P16 positive in contrast to tumors of endometrial origin, which most often have a patchy pattern of P16 expression. Then clear cell carcinoma, which is seen in the upper microphotograph, clear or hobnail cells whose architectural patterns are solid, tubulocystic or papillary. They are rare and have arisen in distinct populations associated with hormone exposure, and serous carcinoma as seen in the lower microphotograph, the rare adenocarcinoma of the cervix, histological appearance to endometrial or adnexal serous carcinomas. It is an aggressive tumor with poor prognosis, associated with older age, higher stage, tumors greater than 2 cm, invasion greater than 1 cm, lymph node metastasis, and elevated serum CA-125. Then there can be the mesonephric carcinoma, adenocarcinoma arising from mesonephric remnants. These tumors are not associated with high-risk HPV. The rare adenocarcinoma variant, wide age of presentation with mean of about 50 years. These tumors commonly arise in the lateral to posterior cervical wall, may be deeply invasive and bulky or exophytic. These neoplasms may be indolent and have a propensity for late recurrence and metastasis. They are uniformly reactive for cytokeratin and IMA and often express calcitonin, vimentin, and CD10. They are typically negative for estrogen and progesterone receptor and CEA. They may express PAC8, PTF, and CP16. Then these 4 photomicrographs, the first one patient. Second one is the glassy cell carcinoma with sharp cytoplasmic margins with ground glass eosinophilic cytoplasm. The third is the adenoid basal, and fourth is adenoid cystic carcinoma. Then the neuroendocrine carcinoma, neuroendocrine tumors. Neuroendocrine tumors could be the low-grade neuroendocrine tumors, which are extremely rare. The grade 1, which are the typical carcinoid, and grade 2, the atypical carcinoid. So for carcinoid tumor, low-grade neuroendocrine tumor grade 1, and for atypical carcinoid, low-grade neuroendocrine tumor grade 2. High-risk HPV-18 can be identified in most cervical neuroendocrine tumors. The presentation may be similar to the other cervical carcinomas, and as you see here, the pattern in the photomicrograph, grade 1, the carcinoid, having abundant cytoplasm, granular chromatin, and visible to prominent nucleoli, and the growth pattern can be organoid, spindle, nested, island, or trabecular. Grade 2 tumors are distinguished from grade 1 tumors by greater nuclear atypia and mitotic activity, as well as rare areas of necrosis. I'd say like the neuroendocrine markers, synaptophysin, chromogranin, CD56, and NAC. The most frequent allelic loss is localized 3p deletion. Grade 1 follow an indolent course. Grade 2, they are more aggressive. High-grade neuroendocrine carcinomas, they are small cell neuroendocrine, and the high-grade neuroendocrine carcinoma, large cell type. Small cell type, they are aggressive and they are having small cell morphology with monotonous population of small cells with ovoid hyperchromatic nuclei with molding and scanty cytoplasm. High-grade neuroendocrine carcinoma of large cell type has a diffuse organoid trabecular or cord-like pattern. Differential diagnosis includes cervical carcinomas of both squamous and glandular type. HPV-18 is identified more frequently than in cervical squamous cell carcinoma. This is the histological features which can be help in identifying the various tumors with the patterns, mitosis, nuclear atypia, neurosecretory granules, and necrosis. So we see here in large cell neuroendocrine, it is moderate, the necrosis, but the mitosis is 10 out of 10 high power fields with marked nuclear atypia, and small cell is extensive necrosis. Mitosis is 10 per 10 high power field, but the nuclear atypia is moderate. Neuroendocrine carcinoma, the IHC may provide support, but sometimes they may not express neuroendocrine markers. TGF1 may sometimes come positive. So basically the morphology helps, and CD56 and synaptophysin are the more sensitive markers for small cell neuroendocrine carcinoma. Large cell neuroendocrine carcinomas may be P63 positive. Then there are the mesenchymal tumors and tumor-like lesions like leiomyoma, angiosarcoma, embryonal rhabdomyosarcoma, the malignant peripheral nerve sheath tumors. I have not described them too much of details because they are very rare. Then there are adenosarcomas and malignant melanoma. So, for the neuroendocrine tumors, some questions like typical carcinoids which lack nuclear atypia, mitotic figures, and necrosis. So necrosis is not a feature of typical carcinoids, and in tunnel clusters, what we see inside a tunnel cluster, it is positive for PAX2, negative P16 and CEA, and Ki67 is less than 1%, with variable HIK1083. The type A tunnel clusters are positive for PAX2 and negative for P16 and CEA. This is a gastric type of adenocarcinoma in situ. They are characterized by negative or focal staining for P16 with variable Ki67 index and focal estrogen receptor staining. And this is second is the HPV-related usual type adenocarcinoma in situ. It is characterized by diffuse block-like staining for P16, high Ki67 index, and negative or focal estrogen receptor expression. So my references are mostly pathology, Femur genital tract, WHO book, and the Diagnostic Histopathology of Tumors, the latest 5th edition. Thank you.
Thank you so much, ma'am. Wonderful. You have covered almost every part of it with the relevant requirements and touched every aspect from in situ to frank tumors to neuroendocrine tumors to mesenchymal tumors. Wonderful lecture. Excellently done. Thank you so much, ma'am. Excellent.
Thank you. Thank you for the opportunity.
I think you have another lecture on Monday, is it?
Yes, it is the uterus lecture.
Right. Take care. Thank you so much, ma'am. Okay. Take care. Bye-bye.